During this episode of Banner Health's Making the Round podcast, we will be highlighting a special two-part series discussing pancreatic cancer and colon cancer. Today's episode, Detecting Colon Cancer Early. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in, and if you're a regular listener, welcome back. With me today are Banner MD Anderson Cancer Center physicians, Dr. Madappa Kundranda, a gastrointestinal medical oncologist and division chief of cancer medicine, and Dr. Shivakumar Vignesh, section chief of interventional gastroenterology at Banner MD Anderson and professor of medicine at the University of Arizona College of Medicine. Thank you, Dr. Kundranda and Dr. Vignesh, for joining me today, and welcome to Making the Rounds.
Thank you, Bridget.
Thank you, Bridget. Excited to be part of this conversation with Dr. Kundranda.
Oh, we're excited about this as well. Colon cancer screening is incredibly important, as is any cancer screening. Dr. Vignesh, I've been reading a lot that there are increased incidences of early onset colorectal cancer. The current recommendation for adults is that your first colonoscopy should be at 45. What is the recommended screening age, and does that differ if you're a patient who is considered high risk?
Well, thank you for that very important question, Bridget. For a long while, the recommended age to start colon cancer screening was age 50. And it's still okay if patients, start their screening at age 50. But you're absolutely right. Over the last 2 decades, there's been a lot of literature published on early onset colon cancer. And we've noticed that there's a shift at the peak age of onset from the late 60s to the 50s. And therefore, many societies, both gastroenterology and American cancer societies nationally, shifted the age to start colon cancer screening to age 45. And, this is for people with average risk. What do I mean by that? People with no strong family history of colon cancer or no other genetic conditions that increase the risk for colon cancer. We do recommend that they start screening at age 45. But it's, not too late to come for colon cancer screening if you're 50 years old. We'd rather you come to have some sort of colon cancer screening.
Dr. Kundranda, what is considered high risk and what's considered hereditary cancer?
Well, thank you for that question, Bridget. There are a lot of nuances that go into hereditary cancers. However, looking at hereditary cancers, when any family member, especially a first-degree relative such as a father, a mother, a sibling, has a history of cancer, it's important that this patient be evaluated for hereditary cancers. It's also important if they have a second-degree relative, such as a grandparent or an uncle or a niece, that these patients are evaluated and not necessarily need to be tested, but nevertheless evaluated by a genetics counselor. That is what we offer here at Banner MD Anderson, to make sure that each of these patients do have that personalized attention to make a determination whether this truly is a hereditary form of cancer or not. Now, any hereditary form of cancer, if that is proven, certainly increases the risk from an average risk to a much higher risk. However, there are other conditions that can also increase the risk of these patients and put them into the higher category, including having individual second cancers, which most patients, unfortunately, because our patient population in the United States are living longer, they tend to be developing secondary malignancies or secondary cancers, which also increases their risk. These are things that can only be evaluated on a patient-to-patient basis, and general guidelines in the context of that can miss a lot of these nuances.
As you mentioned, hereditary conditions can raise your chances in getting certain types of cancer. What is considered a close family member, and how does that familial tie increase the patient's cancer risks?
So as it pertains to colon cancer, there are certain syndromes such as Lynch syndrome and the like, that truly increase the patient's risk for these hereditary forms of cancers. However, one of the other things to be kept in mind is there are these familial clusters that are seen. These could be hereditary. In most cases, they're not. This is when you have a sibling that's affected with cancer. However, these patients need to be evaluated. With that being said, between familial and with hereditary forms of cancer, those are still a minority, with almost 2/3 and higher of these patients, when they're diagnosed with colon cancer, are diagnosed with a sporadic form of colon cancer. And that is what Dr. Vignesh indicated, wherein these patients would still need to be screened at whatever age and it's never too late to be screened. And it's important that we recognize these sporadic conditions as well, because screening serves two purposes. One is to prevent the cancer from even occurring. The second thing is, if it is a cancer, we're hoping that screening picks up an early cancer when a patient can potentially be cured of the disease and not just managed in the palliative setting.
Is there a difference between hereditary and familial cancer?
There is a difference between hereditary and familial. Hereditary cancers are those wherein the gene is passed on from a parent to a child and the next generation. With the familial forms of cancers, these can occur in clusters, but doesn't necessarily have to have a hereditary component to that. Nevertheless, you could, and this is where testing is important. Genetic testing and genetic counseling becomes integral as a part of this.
Can you share a little bit more about our genetic testing and the services that we have here at Banner MD Anderson?
Yeah, thank you so much, Bridget, for that question, because I think when we look at the whole continuum of care of patients, although most patients do not have a genetic component to that, almost any patient who is a young adult who is diagnosed with colon cancer at least gets a visit to our genetic counselors. The genetic counselors take a comprehensive history, including their family history, to determine if genetic testing is appropriate or not. But nevertheless, this is a service that we provide to any patient that walks into the cancer center with a history of colon cancer, especially in our young adults.
Yeah, thank you for those important questions and answers. And I just wanted to add, we often will see patients for other conditions, and we ask a family history. And often that unearths, a strong family history, whether it's in first or second degree relatives. And we send patients to the genetic counselor for that reason that might impact surveillance and screening for other cancers and their family members. And I just wanted to add one other point about this screening. Patients should not wait until they develop symptoms such as bleeding or changes in their bowel habit. Those symptoms would warrant an immediate colonoscopy, but it may be too late in terms of early diagnosis. So even if you're healthy, the message is you must discuss colon cancer screening with your primary care physician at age 45.
And speaking of screening, Dr. Vignesh, can you share with us what modalities are used for early detection of colon cancer?
I would categorize the different modalities as stool tests, a special type of CAT scan called CT colonography, and a screening colonoscopy. With respect to stool tests, there are different options. The most sensitive option that's out there now, commercially available, is the stool DNA test. It's also called Cologuard. It tests for about 11 different biomarkers, genetic markers for colon cancer, and also tests for this globin, which is part of the blood protein. And therefore, it picks up almost 90 to 92% of colon cancers early, and it can detect advanced polyps. There are some other stool tests in the interest of time that I won't mention, but the old occult blood test should not be performed because that has very poor performance in terms of detecting polyps and not acceptable performance for cancer. In terms of the other modality called CT colonography, it's a special type of CAT scan that can look at the entire colon and detect cancer as well, and it detects large polyps, but it can miss small polyps. So that's another option. It still needs the person to drink a laxative to clean the colon, and it also requires the colon to be insufflated with air. And if something is detected, patients will need a colonoscopy follow-up. Now, the last but not the least is a screening colonoscopy, which is what, as gastroenterologists, we perform to detect colon cancer. Now, it's not only a test to detect colon cancer and polyps, which it does a great job with. Polyps as small as 3-4 millimeters are easily detected, but we're able to remove these polyps at the same session. And that's really the benefit of colonoscopy. It detects and it prevents colon cancer by removing the polyps. And that's what we would recommend as the preferred screening test for patients who are healthy to undergo that.
Dr. Vignesh, you had mentioned Cologuard, the at-home stool and DNA test. What is the percentage of false positives, and how does a referring physician or a patient navigate those results?
So about 13% of the time you do get a false positive result, which means there's no colon cancer, but the test is positive. That could be because there's some bleeding from another part of the gut, because it does detect blood. And rarely it may show cancers in other part of the GI tract. And about 10% of the time the test is false negative. So it can miss cancers too. It's not 100%. But I still want to say among the stool tests, it's one of the best options available.
Dr. Vignesh, going back to the false negative of the 10%, so if you have a patient who is in their mid-50s, does not have a family history, when would, other than the patient developing symptoms, if they've had a negative stool DNA test, is there anything else in your mind that would be a trigger for them to bring it up with their primary care physician or healthcare provider to say, yes, we've been doing these tests, however, this is my trigger to probably get a colonoscopy?
Thank you for that question. It's very important to address. Yeah, as we just discussed, these tests are not 100%. They do miss cancer roughly 10% of the time. So as a gastroenterologist, I would still recommend that they absolutely discuss these results with their primary care physician or a gastroenterologist. Some patients don't have to go through a primary care physician. And we would recommend they still undergo a colonoscopy. Because colonoscopy, even though it's a minimally invasive procedure, it's a short procedure that vast majority of patients can tolerate. And unless there's a very good reason not to perform a colonoscopy, I would still, encourage them to undergo a screening colonoscopy, because the ability to detect polyps and cancers is roughly 95%. Even colonoscopy, there's a very small miss rate, but it's the best option for screening. And we do want to get that message across.
And Bridget, I think that's such an important message for listeners, because when you think about these tests, this is for somebody, I had a family member, my dad had colon cancer. So when you think about all of this is such an important message to convey, that even if you have a negative stool test, it is still the gold standard to still get a colonoscopy at an appropriate time.
Thank you for that, gentlemen. I appreciate that oversight. So we're familiar with gastroenterologists, but can you tell us more, Dr. Vignesh, what is the importance of an advanced interventional gastroenterologist in the diagnosis of colon cancer and part of that care team?
Yeah, so interventional gastroenterologists undergo additional years of training to perform certain procedures, that can be used to either remove very large polyps or treat cancers of the GI tract, for example, pancreas and bile duct and other interventions. And, the advantage that we have is, we both have new technologies, better imaging to detect colon cancer and large polyps, but we may be able to save some patients a major surgery by our ability to endoscopically, which in this context would be with a colonoscopy, remove these large polyps. And in certain cases, we can even remove very early stage cancer, especially of the stomach. So it's important for patients to be aware of this option. In our cancer center, we discuss all these scenarios in our tumor board, which is interdisciplinary, and we do what's best for that patient.
When would a referring physician, when would a primary care send to an interventional gastroenterologist versus a general gastroenterologist?
That's a good question. Usually we get our referrals from a general gastroenterologist, say, who's detected this large polyp, and the patient is either a high-risk candidate for surgery or they're aware of our ability to remove these polyps with a colonoscopy. It's good for the primary care physicians to also be aware of that. Within our cancer center, even our surgical oncologists and us work together, and we do, like I said, what's the best option for the patient. But broadly, if the patient has, say, a pancreatic mass or a pancreatic cyst or a bile duct blockage, which may be benign, may be cancer, as an interventional gastroenterologist, we're able to help with all those conditions, both from a diagnostic perspective and sometimes to relieve a blockage or jaundice. That's a very broad question, but sure. I think it's, we have the ability to diagnose and treat cancers of the GI tract.
Thank you for that. And obviously, with the two of you being here today, gastrointestinal medical oncologist, an advanced interventional gastroenterologist, we are really looking at a multidisciplinary team here. Dr. Kundranda, Banner MD Anderson Cancer Center utilizes a multidisciplinary approach. Can you share with us what does that mean in the treatment of GI cancers?
Thank you, Bridget. I think this is an important question to understand exactly what we do. As we've known, gastrointestinal malignancies and cancers, the treatment and management of that has evolved and has become a lot more complex. Gone are the days wherein it was medical oncology, surgical oncology, and radiation oncology. Right now, when we think about multidisciplinary care for any GI malignancies, it comprises of cutting-edge clinical therapies, whether it is through a surgical oncologist or any of the traditional modalities, but equally important is the supportive arm component of gastrointestinal malignancy care. The supportive component is an integral part of it because that includes, for example, a dietitian who can work with the patient to try to optimize his or her nutritional status. A psycho-oncologist, these are psychologists who are trained to work with patients with cancers, not just work with them, but also work with their loved ones who are caring for these patients with cancers and helping them through this journey. Because this is a marathon, it's not a sprint. And supporting a patient and the family member, both from a medical standpoint, a psychosocial standpoint, for physical support, emotional support, and treating the patient as a whole is a key part of this. In addition to that, most of the cases which are more complex and requires multidisciplinary care get discussed at a multidisciplinary tumor board, like Dr. Vignesh indicated. At this, we have the entirety of our team, including our genetic counselors who are there, who chime in and say that this might be something that wherein we need to look at this being a genetic disorder and that needs to be addressed and hence warrants a consultation with them. So when you bring the whole team together, and that's the reason when they say it takes a village to raise a child, it truly takes a village to care for a patient with cancer. And that's what we do here at Banner MD Anderson.
Yeah, no, I couldn't agree more with what Dr. Kundranda says. That's one of the reasons that drew me to the Cancer Center as an interventional gastroenterologist, because, most of the very advanced interventions, they work best in the context of, an interdisciplinary approach. We do have these very good, robust tumor board discussions, and if I see a patient with a very large colon polyp, in the topic of today's discussion, and we have some pathological diagnosis and imaging, I would first review it in our tumor board and make sure that we all agree that the best option for that patient is an endoscopic resection. Not just because I'm able to perform it, but we have this robust interdisciplinary discussion to come up with a consensus plan for each patient. And in terms of the supportive, if I might add, a lot of interventions that interventional gastroenterologists perform are not just for treatment, but palliative. It might be relieving biliary obstruction or bile duct obstruction and jaundice in a patient with advanced pancreatic cancer. We can do interventions to treat pain, intractable pain in advanced pancreatic cancer, for example, by blocking this nerve ganglion called the celiac plexus. We can place stents to relieve obstruction by colon or rectal cancer, either to palliate obstruction or as a bridge to surgery. So these are, interventions we do to support the care along with the medical oncologist and the surgical oncologist.
So as we're addressing the multidisciplinary team, the connection and the continued collaboration with the referring provider, whether it's the general gastroenterologist or the PCP, is really important with this team, as part of that continuum of care. What is that referral pathway into Banner MD Anderson, and where does that patient start?
Well, thank you for that question. I'm going to answer it in two parts. In terms of colon cancer screening, I think it's important for everyone to know that we have a very robust and very well-run open access program. It's also called a direct access program for colon cancer screening, because we're referring to patients who are healthy in their 40s, 45 to 50, and they don't really need a consultation with a gastroenterologist with a referral from a PCP, or sometimes the patient can directly call our Banner MD Anderson clinic and will be forwarded to the open access program, where a well-qualified nurse can talk to them about a screening colonoscopy and even order the prep, or the laxative to cleanse the colon. And they meet with the physician on the morning of the procedure. It works quite well in terms of improving access to a screening colonoscopy. Now the patient has the option to ask to speak with a doctor or a nurse practitioner if they choose to do so. Now, in terms of overall referrals, we have this new patient scheduling, for patients who, are new to the Cancer Center. and they have a nurse in addition to schedulers who's able to talk to patients and who also reaches out to the appropriate specialist to make sure the patients are appropriately scheduled.
Thank you both for this information. We have an amazing team here at Banner MD Anderson, and Dr. Kundranda and Dr. Vignesh. I can't thank you enough for taking time to speak with us today and educating us on the evidence-based strategies for detecting colon cancer early. Any closing thoughts?
Well, I have a couple of take-home messages. Thanks again for this opportunity. Get screened. That's the most important message. Don't worry about what option. But, at age 45, I would encourage you to go speak to your primary care physician. And, if you're already 50, it's definitely not too late. Just discuss options with your primary care physician. As a gastroenterologist, I still recommend a screening colonoscopy. As Dr. Kundranda said, remains the gold standard because it's the best test that detects the precancerous polyp. However small they are, we're able to detect it, and we're able to remove the polyp, and therefore we prevent the polyp turning into cancer. And also, I want people to know that we as interventional gastroenterologists at Banner MD Anderson are able to offer a variety of services and remove large colon polyps that may save patients a major surgery.
Thank you, Bridget. I will just add to that 2 comments. Number 1 is that we work as a team and everything revolves around the patient. And it's all under one roof. The second point is, again, going back to the complexity of GI malignancy and the management of that. If you're ever uncomfortable or if you feel like your patient feels like they don't understand the process of the disease process, we're here for second opinions. That's what we provide here. So we are here for our patients and for our PCPs, and anything that you can let us do to help you with this journey, that's why we're here.
Thank you both.
Thank you, Bridget.
Thank you, Bridget.
To learn more about the gastrointestinal cancer services available at Banner MD Anderson Cancer Center, please visit bannerhealth.com/cancer for more information. Thank you for listening, and we'll see you next time on Making the Rounds.